From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Intravenous thrombolytic therapy is a mainstay of treatment for patients with acute ischemic stroke who present to medical attention quickly and don't have contraindications to treatment. Alteplase is the clot-busting drug that's commonly used in the United States for acute stroke. Many clinicians simply refer to it as IV TPA. 2 articles have been published recently in JAMA describing the use of alteplase in different contexts for the treatment of acute ischemic stroke. Using these articles and also other recently published studies, today we'll discuss the role of thrombolytic therapy as well as mechanical thrombectomy in the management of acute ischemic stroke, summarizing the current thinking about the use of these treatments and also what the future might hold. I'm Christopher Muth, Senior Editor at JAMA, and I'm joined today by Dr. Jeff Saver to discuss some of these issues. Dr. Saver is a neurologist and professor of neurology at UCLA, University of California, Los Angeles. Not only is he a world-renowned expert in vascular neurology, but he also just happens to be a JAMA Associate Editor. So thanks for joining me today, Jeff.
A great pleasure to be here with you, Chris, and with the JAMA audience.
So to begin with, can you summarize the decision-making for management of acute stroke? In general, which patients should we be thinking about giving thrombolytic therapy, and which patients are eligible for mechanical thrombectomy?
Yes, well, for intravenous thrombolytic therapy, the guideline indication is treatment within 4.5 hours of last known well time. And for patients whose acute ischemic stroke is causing a disabling deficit, and that's whether it's due to a large vessel, medium vessel, or small vessel occlusion. There are several clinical trials that have been reported in the last 2 years that have shown that imaging selection of the subset of patients beyond 4.5 hours and up to 9 to 12 hours who still have salvageable tissue can identify patients who will benefit from late intravenous thrombolysis, and that is likely to migrate into the guidelines more fully in years to come, and I think is also a practice that is sometimes used very reasonably in the U.S. Endovascular thrombectomy is currently employed for patients primarily who have large vessel occlusions in the basal cerebral vessels and the most severe types of strokes. It has the evidence for broad application in patients up to 6 hours from last known well, and also benefit in imaging selected patients in the 6 to 24-hour window.
Okay, great. And so with that as background, I wanted to talk a little bit about some of the nuances in using IV thrombolytics to start. So specifically, one of the contraindications for IV thrombolytics might be for patients who are receiving anticoagulation. Can you tell me a little bit about the details of when that contraindication applies to the use of IV thrombolytics?
Yes, there is good data that the added bleeding risk of anticoagulants when thrombolytics are given outweighs the benefit of thrombolytics. And so active anticoagulation is a contraindication to IV lytics. With agents whose presence is well identified from serum studies, such as warfarin that elevates the INR or heparin that increases PTT, then abnormal blood levels indicating therapeutic doses of these agents is a contraindication, for example, an INR higher than 1.7. For the NOACs, for which serum tests for their current effects is less available, the current indication is to not treat patients if they report having taken a NOAC within 48 hours prior to presentation. Based on their half-lives, patients who've taken NOACs beyond 48 hours ago should now have low enough levels to be safe, but within the prior 48 hours, that is a contraindication.
And that leads nicely into one of the studies recently published in JAMA that I wanted to discuss with you. You were a co-author of the study, and the title was association of recent use of non-vitamin K antagonist oral anticoagulants with intracranial hemorrhage among patients with acute ischemic stroke treated with alteplase. And so this study essentially was honing in on that group that you were just mentioning, the patients who are taking NOACs, and whether or not alteplase could be used in that population. Can you tell me a little bit about the design of this study and the question that it was trying to address?
Yes, this was a large observational study looking at the data collected in the Get With the Guidelines National Quality Improvement Registry in the United States over a 5-year period from 2015 to 2020. The registry covers about 70 to 75% of all acute ischemic stroke admissions in the U.S. And the goal was to determine the safety of giving intravenous alteplase in patients taking NOACs. The guideline recommendation that it is safe to use if taken more than 48 hours ago is based mostly on physiologic evidence and not actual clinical data. And there also are times when clinicians may be using it within 48 hours. So it was important to show that the use per guideline is safe. And that was the main goal of this study.
And what were the main findings of the study?
Well, of 160,000 plus intravenous alteplase treated patients during this time period analyzed in the study, about 1.5%, a little over 2,700 patients, were patients who had been taking NOACs recently. The Get With Guidelines registry records if NOACs have been taken in the past 7 days or other anticoagulants. That time cutoff is from the warfarin era, and it's not yet been updated to have a 48-hour window. So we know about these patients that they took NOACs within the last 7 days, and they went on to get lytic therapy. And we found that the outcomes in these patients were very reassuring. There was not an increased rate of symptomatic hemorrhage in the NOAC patients receiving alteplase compared to the non-NOAC patients receiving alteplase once you adjust for the differences in patient characteristics, because patients on NOACs often have cardioembolic sources of stroke that cause more severe infarcts and also tend to be older. In addition, there actually was a suggestion of better outcomes after adjustment for the patients on NOACs, with odds ratio showing higher rates of patients being functionally independent and disability-free at the time of discharge. So overall, this provided very reassuring supportive evidence for the use of alteplase in patients recently receiving NOACs as currently practiced in the U.S., where it's primarily, I think, among patients who are known to have had their last deaths between 48 hours ago and 7 days ago.
That's an important point, I think, that this study can help demonstrate that it appears to be a safe practice to use alteplase in the patients who were receiving NOACs. Presumably most of them in this study had had the NOAC probably more than 48 hours prior to their stroke. The other interesting wrinkle that this study included was that there was a small subset of patients for which there was more granular data available about the exact time of their last NOAC use. Can you tell us a little bit about that piece of the study?
Yes, in the Aramis sub-study, there was detailed information on the timing of the NOAC usage in a very small group of patients, only 47 patients, but it provided some useful insights, at least to me. For example, nearly half of the patients in this subset received the NOAC within 48 hours of onset, and a little more than half between 48 hours and 7 days. And that's more than I had expected. It suggests that maybe in the larger group, more patients were treated with NOACs use within the last 48 hours than we might have expected. On the other hand, The Aramis study was performed at research-focused academic hospitals who may be more comfortable treating beyond the guidelines within 48 hours. I'll also note that treatment within 48 hours often occurs when patients arrive and it is not known that they are taking NOACs at baseline, and the initial history does not unveil that, and treatment is given, and then only later, after the fact, is it discovered that they were on NOACs and had their dose within that time window. But when in this small group of patients, when they looked at within 48 hours versus beyond 48 hours, there was not a major difference in hemorrhage rates or outcomes, which suggests with the NOACs that although there probably is going to be some increased risk, it's not a dramatically increased risk when you treat within 48 hours.
Yeah, I think out of the 25 patients who had been treated with a NOAC within 48 hours and then got the alteplase, 2 of them had a symptomatic intracranial hemorrhage. But again, with such small numbers, I think it's a little hard to know for sure. But that certainly seems to be the key area maybe that future research could focus perhaps is, within this 0 to 48 hour window from which when patients have been exposed to NOACs, can alteplase be used? What do you think? I mean, do you think there's a role for using alteplase when a patient has been exposed to a NOAC within the past 48 hours?
Well, let me say, I think it should be used rarely and always with trepidation, because I do think it is going to be associated with an increased risk of adverse effects. If you have a patient who's not a candidate for endovascular thrombectomy, if they're non-navigable to their intracranial vessels, and their only option for a major presenting event that's still reversible is IV lysis, then it may be worth trying, but I think that should be the exception. The future lies in having testing more widely available for serum indications of NOAC use and also the reversibility agents. There is good evidence that at least Praxabind can be used to reverse dabigatran and safely give lytics afterwards, and some evidence that suggests that reversal agents for the factor Xa NOACs can also help reduce bleeding risk.
Okay, great. Yes, and there's actually an editorial that accompanied this paper in JAMA, the editorial written by Dr. David Seafage, who brought up the idea about the potential of using NOAC reversal agents or checking blood levels. But it sounds like perhaps that's not in widespread clinical use at this time. Is that right?
That is the case, at least not in the US. I understand there are some places in Europe and elsewhere where serum checks for different indicators of NOAC use are more routinely available, and there is more guided use of reversal agents before treating. But these patients are relatively few and far between, and it's hard to develop a smooth protocol that is reliably implemented and that also keeps the market small, I think. So we've not really seen uptake of these approaches on large scale in the US, although when available, they're worth doing.
I also wanted to ask you about other types of IV thrombolytics that might be available besides alteplase. Are there any other thrombolytics that are commonly used for acute ischemic stroke?
Well, the other agent that is of particular interest at the moment is tenecteplase. It has a weak endorsement in the national guidelines. It is a third-generation agent that has some physiologic reasons to think it might be a little better in outcomes than alteplase, but it especially has the benefit of being able to be given as a single one-time bolus rather than an hour-long infusion, which makes it easier to send the patient on to another thrombectomy hospital or within a thrombectomy hospital to get them on to the cath lab. There have been several head-to-head trials of tenecteplase at various doses with alteplase, and meta-analyses of those have suggested that it's non-inferior to alteplase, but we're awaiting some large trials that will confirm that and also tell us whether it might be a little superior to alteplase. More and more hospitals here in Los Angeles, where our mobile stroke unit takes patients to different facilities, and we use the agent that the facility uses to treat in the ambulance. And we're having still a minority of hospitals, but more and more have switched over to tenecteplase from alteplase.
Very interesting. And is tenecteplase FDA approved for acute ischemic stroke?
It is not specifically FDA approved for acute ischemic stroke. And so when you have a competent decision maker, that should be a part of the discussion. Although the safest way to switch a hospital over to the use of tenecteplase is to stock only tenecteplase in order to avoid people being mixed up and giving the wrong dose of one agent versus the other. And when you do that, then the only choice available to the patient is the tenecteplase. But it is on guideline and a reasonable approach to take.
Very interesting. Those are good things to think about. Okay, and then moving on to mechanical thrombectomy or endovascular thrombectomy. Let's talk about some of the nuances about using that treatment. So first of all, there seems to have been a shift over the past few years from focusing exclusively on the time to treatment, the time from when the patient was last known well until they're presenting, letting that be the rate limiting factor in deciding whether or not endovascular thrombectomy is possible, to now using more advanced imaging techniques to identify patients who might still benefit even if they're several hours out from the time they were last known normal. Can you explain this?
Yes, the initial wave of pivotal trials in the breakthrough year of 2015 demonstrating the benefit of endovascular thrombectomy predominantly used time as the entry criteria, and most of the patients had start of procedure puncture time within 6 hours of last known well. So that was the initial on-guideline approach. But then in 2018, two trials, Diffuse 3 and Dawn, used imaging selection in longer time windows up to 24 hours using either multimodal CT or multimodal MR penumbral type imaging to identify the size of the ischemic core of irreversibly injured tissue and the size of the surrounding penumbra of threatened but not yet irreversibly injured tissue. And patients with relatively small cores and large penumbras are patients who will still benefit from therapy based on that tissue clock, which is even more important than the time clock. About half of the patients beyond 6 up to 24 hours will have a favorable pattern per those criteria. And under 6 hours, almost everybody has a favorable pattern. So the need to do penumbral imaging is less strong when patients present early because time alone is a good index of having salvageable tissue. But once you get beyond 6 hours, the physiologic imaging is helpful.
Yes, so that's certainly an important shift in the way clinicians are thinking about who might be eligible for endovascular thrombectomy. The other thing that's been a potential shift is the use of IV thrombolytic medication along with endovascular thrombectomy. So my understanding is that most patients, if they're eligible and present within the time window for IV thrombolytics, they'll first receive an IV thrombolytic, and then if they have a large vessel occlusion, might proceed to mechanical thrombectomy. But there's been some studies that have been looking at whether or not a patient could just go straight to thrombectomy without getting IV thrombolytics first. Can you comment on that?
Yes, the direct to thrombectomy strategy has advantages of speed and not exposing patients to the risk of hemorrhagic transformation from lytics. The give lytic strategy has the potential benefits of earlier reopening and also synergistic effect with thrombectomy on reopening. And as a result, a wave of trials has been coming out evaluating the skip lytics direct to thrombectomy strategy. 6 trials have been podium reported, 4, I think, published, including 2 in JAMA. And overall, the direct to thrombectomy approach seems to be about the same as the combined lytic and thrombectomy. Non-inferiority margins are being met by the trials. There's a little bit of a suggestion that in Asian countries, they might be more equal, and in non-Asian countries, there might be a slight overall benefit of combined therapy over direct, but we have to wait for the pooled analyses to come out to really know that. But I think the big picture view is that they are pretty similar. And so it's reasonable to decide in each case whether to go ahead with the standard default pathway of giving lytics on the way to thrombectomy, or when a patient has a particularly large clot in the carotid T occlusion or relative contraindications to lytics, to go ahead and skip the lytics and go straight to thrombectomy.
And of course, I think, correct me if I'm wrong, part of the decision-making would also have to factor in how quickly a patient could be taken directly to thrombectomy. Is that right?
Absolutely. The skip strategy is only possible at hospitals that are thrombectomy centers, and when you know that the team and table are going to be available in a timely fashion. For patients who present to primary stroke centers or acute stroke ready hospitals that provide lytics but don't have on-scene thrombectomy and are going to have a long time before they get to a thrombectomy center by interfacility transfer, it's important to go ahead and give the lytic as the best chance for an early reperfusion the patient has.
Okay. And then I want to shift now a little bit and talk about another paper that was recently published in JAMA. There's an interesting preliminary report that describes the use of intra-arterial alteplase after mechanical thrombectomy in selected patients who've had a successful thrombectomy procedure. But before we get into the details, can you just explain what the rationale of giving intra-arterial alteplase after thrombectomy might be?
Yes, this is for patients in whom thrombectomy has been at least somewhat successful. There's another use of intra-arterial lytics as a rescue therapy. When you couldn't get the clot out mechanically, you can try to dissolve it with intra-arterial lytics. But that's not what this trial examined. These were patients who had at least 50% reopening of the artery. And in those patients, lytics have two potential benefits. One is for patients who have partial reopening but still have clots in distal arteries, the lytics can perform cleanup of those smaller but visible thrombi and reopen their territories, reaching remaining clots that the large devices can't get out to. The other very intriguing idea is that even in territories where there's no visible remaining occlusion, that the no reflow phenomenon may be happening, which is well known from preclinical models of ischemia, that in ischemic tissue, the vessels at the arteriolar and capillary level may become closed off, often clogged with microthrombi, and all of the visible vessels on angiography will appear to fill and drain normally, but the tissue at the capillary level won't actually be receiving useful perfusion. And that is another potential benefit of giving IA lytics into the reperfused field, and that is clearing out the microcirculation and removing the no reflow phenomenon.
Okay, and so with that background then, to talk a little bit in more detail about the study that was published in JAMA, the title was Effect of Intra-Arterial Alteplase versus Placebo Following Successful Thrombectomy on Functional Outcomes in Patients with Large Vessel Occlusion, Acute Ischemic Stroke. And this was a phase 2B randomized trial with 121 patients. It was stopped early, in part, I think, due to difficulties related to the COVID-19 pandemic. But can you tell us a little bit about the population that was studied here in this trial and the main outcomes of the study?
Yes, they originally planned to have 200 patients, but then the availability of the placebo, and this was a placebo-controlled study, disappeared with the COVID period, and they did end up with 121 patients. All of the patients were patients with large vessel occlusions in the anterior circulation who underwent endovascular thrombectomy and had at least a TICI 2B response, which means reopening at least 50%, either 50 to 89%, which would be a 2B response, 90 to 99%, which would be a 2C response, or the ETICI-3, which would be a 100% angiographic reopening. And it's those patients in whom reopening was achieved that were randomized to receive an additional infusion of IA alteplase or IA placebo.
Okay. And then the main outcome was looking at patients who achieved a score of 0 or 1 on the modified Rankin scale at 90 days, which is a quite good outcome, essentially a patient that doesn't have disability. And the proportion of patients that had that modified Rankin scale score of 0 to 1 at 90 days was 59% with alteplase and 40.4% with placebo, which was statistically significant.
Yes, that was a dramatic difference in the outcomes, and we have to be careful with this smallish phase 2B trial that has wide confidence intervals in concluding that this is the effect that we'll see when we have larger data. But it's certainly strongly indicative that this strategy of using cleanup lytics in patients with reperfusion is a very promising one that may well increase and perhaps substantially increase the number of patients in whom excellent non-disabled outcomes are achieved at 3 months.
Yes, and I thought it was potentially important too. The patients could have received IV alteplase, then they had their thrombectomy, and if they achieved good reperfusion after the procedure, then they get IA alteplase. It seemed to be quite a lot of alteplase to me, and so it was important to see, was there any adverse effects? And there didn't seem to be a major sign of hemorrhage different between the two groups.
That's right. There was not a statistically significant difference in the hemorrhage. The dose of alteplase given IA was up to a quarter of the standard IV dose. And because it's given in the territory in which the thrombi are, it will yield a higher concentration, even given at a lower dose. The strategy of combined IV and IA lysis was a promising one back in the pre-thrombectomy era, the very first endovascular approaches to reopening arteries in the early 1990s were pure IA lytic strategies. And they were percolating along, making some progress, but it took some time for the dissolution to occur, and they didn't work great on the really big thrombi, and the devices came along and did that better. So the IA lytic strategy was retired for a time period, but the idea of the benefit of cleanup lytics has always persisted, and it's been used in practice in occasional cases. And this is the first rigorous trial suggesting that it might have a role to play in the EVT era.
Okay, and then you mentioned that the findings should be interpreted somewhat cautiously, one of the points being that the trial was stopped early and there were wide confidence intervals around some of the estimates. Were there any other limitations or nuances to consider? I suppose another one would be that this doesn't apply to all patients who are receiving thrombectomy, but only that subset that had successful thrombectomy. But any other considerations when interpreting the findings?
Yes, because it was a small study, there were some imbalances in patient characteristics, especially at an earlier time to treatment in the active IA lytic group with adjustment for imbalances. There was not, the benefit still seemed to persist, but we always have to be concerned about residual or unmeasured confounding.
Yes, and in thinking about some of the implications and some of the nuances in interpreting the findings, there was also an enlightening editorial that accompanied this article in JAMA by Dr. Pooja Khatri. So it seems to me like the bottom line is that these findings are quite interesting and provocative, but would it be fair to say that they're not quite ready for clinical practice until additional studies can confirm these findings?
Absolutely. I think this is a very welcome suggestion that this will be a useful path to tread, but we need to have it confirmed in larger sample sizes. And this trial was confined solely to Catalonia, Spain. So we need more heterogeneous populations to know that it's really widely beneficial.
Okay. And then we've been talking a lot about different uses of thrombolytics and in combination with mechanical thrombectomy. Are there any other variations of those approaches that you think might be worth mentioning now? Or have we covered most of the main ones?
I think another interesting next domain are medium vessel occlusions. The catheters, both aspiration devices and stent retrievers, are getting smaller and more navigable, and now can more and more reliably reach more distal medium-sized vessels, which historically have been the prerogative solely of IV lytic strategies. So we're going to see head-to-head trials of IV lytics versus thrombectomy for MVOs, medium vessel occlusions, and also trials of combined IV lytics and thrombectomy for MVOs.
Okay, very interesting. Well, Jeff, thank you very much for talking with me. It seems that the stroke research community is continuing to explore the best ways of using the thrombolytic medications and thrombectomy devices to get the best benefits for patients. Do you have any final thoughts to sum things up before we go?
Well, I'm thinking of Thorsten Veblen, who said, the outcome of any serious research is to make two questions grow where only one grew before. And that's what we're seeing in this wonderful therapeutic era for stroke care, where we are keep iterating and innovating for the benefit of patients.
Thanks a lot. So to summarize, as has been the case for quite a while, IV alteplase certainly has a role in treatment of acute ischemic stroke, and more is being done to expand its use to patients who might have previously had contraindications, such as patients with recent use of NOACs. There are also different thrombolytics, in particular tenecteplase, that are potentially available and perhaps have certain advantages over alteplase. Regarding mechanical thrombectomy for patients with large vessel occlusion, research is looking at whether it might be possible to bypass IV thrombolytics before the procedure and instead proceed direct to mechanical thrombectomy for some patients. And the results of a recent preliminary study published in JAMA suggest there may be a role for intra-arterial alteplase to be delivered after mechanical removal of a clot, perhaps with benefits related to alteplase's effects on the distal microcirculation. That's all for this episode of JAMA Clinical Reviews. I'm Chris Muth, Senior Editor at JAMA, and I'd like to give a very special thanks to Dr. Jeff Saver for speaking with us today. This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Jesse McQuarters, Shelley Steffens, Lisa Harden, Audrey Foreman, and Marilyn Ferkaluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.